Hi everyone. Thank you so much for being here today. You're joining us today for our workshop with CATIE, HIV Basics. For your information, all participants' microphones are muted today. If you have any questions, we ask that you please use the Q&A box that is in the bottom center of your Zoom Windows taskbar. The chat box is also available if you have any comments or technical support questions during the presentation. As a reminder, this webinar is being recorded, and the recording will be available on the Saskatchewan Prevention Institute website and will be emailed to you in the coming days. Before we get started, I want to do a quick land acknowledgement. I'm recording this webinar today from Saskatchewan, which is located on treaty lands 2, 4, 5, 6, 8, and 10, and the ancestral territories of the Nehiniwak, Nehitawak, Nahayawak, Anishinaabeg, Nakaway, Dakota, Lakota, Nakota, Dene, and the homeland of the Métis. If you hear kids in the background, it's because we're connected to a school and I think they just came in from recess, so sorry if that's a little loud. We recognize that these lands are currently inhabited by Indigenous people from across Turtle Island, including many other First Nations and Inuit peoples, and acknowledge the importance of the treaties, the lasting impacts of colonization, and continued inequities. We are dedicated to moving forward on a shared path of reconciliation and partnership. We are all treaty people, and we're grateful to live, work, and play on this land. So my name is Abby Gertzen. I'm the Sexual and Reproductive Health Program Coordinator at the Saskatchewan Prevention Institute. Our mandate at the Saskatchewan Prevention Institute is to help all children thrive through primary prevention and the promotion of well-being. We believe that children of all abilities have the right to the best physical, social, and emotional health possible. Our goal is healthy children. We provide education, training, and capacity building across 6 main program pillars: early childhood mental health, prevention of child abuse and neglect, prevention of child injury, prevention of fetal alcohol spectrum disorder, perinatal and infant health, and sexual and reproductive health. One goal of the Sexual and Reproductive Health Program is to provide educational sessions for health and allied health professionals and the public about STBBI and reproductive health. So this workshop today is CATIE's HIV Basics Workshop, which is an introductory-level workshop geared towards service providers who work with people at risk of or living with HIV. This session aims to provide service providers working with community-based organizations with the foundational knowledge of HIV. I'm sure Shreya will also go into an overview, so that's just my quick overview. So here to present to us today is Shreya Hari. Shreya Hari is currently based in Toronto, where she works with CATIE, Canada's official knowledge broker for HIV, hepatitis C, and STBBIs. At CATIE, she is a health educator. Her work includes a wide range of educational delivery, including workshops, courses, and webinars. Shreya's primary areas of interest include sexual health, HIV/AIDS, hepatitis C, communicable diseases, and chronic illnesses. While she holds 2 degrees from McGill University and the University of Toronto, in her worldview, the entire universe is her university and therefore her place of learning. So without any further ado, I'm so happy to welcome back Shreya Hari. Thanks for being here.
Abby, thank you so much for that warm welcome. It's certainly a pleasure to be back here and working in partnership with the Saskatchewan Prevention Institute to bring everybody this session on HIV basics. I'll just briefly mention, I know you mentioned this, I am indeed working and living in Toronto, and I just wanted to briefly acknowledge the lands from which I am joining you all from today. And so it's with deep gratitude and respect that CATIE acknowledges that our work takes place on Indigenous land. Our office is situated on the traditional territories of the Mississaugas of the Credit First Nation, the Haudenosaunee Six Nations, and the Huron-Wendat. This is now home to many diverse First Nations, Inuit, and Métis people today. And we acknowledge also, of course, just like today, that our outreach and education work is also carried out on Indigenous territories across the country, including unceded lands. I'll just take a minute here to share my screen. There we go. And as you can hear, I'm a little bit under the weather, so my apologies. There might be some brief interruptions in today's session with some coughing. But I hope you can bear with me. So welcome, everyone. It's really great that so many of you could find some time today to learn a little bit more about HIV. I'm hoping that today will answer as many questions you might have or that you've heard from the people that you support. It is geared towards an introductory level of HIV understanding, but I also know there's a lot of experience and knowledge in this group and potentially a range of knowledge. We're just going to go over the basics so everyone can be on the same page, but if you have additional questions or insights and things, I welcome your wisdom. You can certainly share in the chat. It will go to me. But if you have questions, please use the Q&A box as Abby mentioned. And there will be some opportunities to sort of answer those questions and so on. There are also some reflection questions throughout this session. And so, I would welcome your answers in the chat when it comes to those questions. And then if we get to the end of our time together and you still have some questions at the end, there might be some time for that as well. And yeah, so I encourage everybody to ask questions and offer your insights throughout this session. I'm not sure how much people here know about CATIE and the work we do, but in a nutshell, we're a national organization working in HIV, hepatitis C, and STBBIs, as well as substance use, health, and harm reduction. And so we support frontline workers by increasing their capacity to respond to the needs of their patients and clients. And one of the ways we do that is through sort of sessions like this, so direct education with folks like yourselves. And so for anyone who wants to learn more about HIV or hepatitis C in greater detail, you can certainly take our online courses, either fully independently or by registering for a regional or national course to learn alongside others working in your field. And our regional and national courses are facilitated by CATIE health educators, including me. All right, so we'll dive into HIV basics and beyond. And so today we're going to briefly share an introduction to HIV in Canada, including a consideration of health equity. We'll talk about the biology of HIV transmission, and then we'll move into prevention, testing, and treatment. And then we'll also talk about what this means within the context of your work. And then at the end, we'll have some evaluations. And this is just some of our learning objectives. So we're hoping that by the end of the session, you'll be able to consider health equity, more comfortably describe and discuss the biology and transmission of HIV, perhaps explain some of the broad tests used to diagnose HIV and describe at least that HIV testing process, and then communicate sort of the basics of HIV treatment to clients, as well as talk a little bit about highly effective HIV prevention strategies. We will lightly touch on testing. We're not going to probably go as in depth with it, but we will have a fact sheet for you as a resource that goes into testing technologies. All right. So let's take a look at who is most impacted by, my apologies. We'll take a look at who is most impacted by HIV in Canada. And so to do this, we want to also recognize that the data that I'll be showing you in a moment doesn't always reflect the variations across and between and within provinces, territories, and communities. And often, many population statistics underrepresent those most affected by HIV. So here are some key points, right? So HIV can affect anyone, no matter their age, sex, gender, sexual orientation, race, or ethnic origin. Health inequities like racism, homelessness, and living with mental health challenges can increase vulnerability to HIV, create barriers to health services, and lead to poorer health outcomes for people living with HIV. And what we know is that at the end of 2020, over 62,700 people were living with HIV in Canada. And actually, I believe those stats have been updated since then. So my apologies. When I send out the final version of this, it'll have an updated number there. This infographic is based on 2022 data from the Public Health Agency of Canada, and it sort of gives us an idea of how differently HIV is being experienced across the country by different communities. And the takeaway from this is that there isn't one HIV epidemic in Canada, but many, depending on where you live, what communities one might belong to, and other structural factors related to the social determinants of health. And again, identity community isn't a sign of risk in that way, but it more so reflects that upstream factor of health inequities, right? So that's important to consider. And as you can see too, yeah, so we do mention this on the slide itself. So it doesn't have Canada doesn't have a single HIV epidemic. There are differences that we see. And here in this infographic, again, based on 2022 data from the Public Health Agency of Canada, you can see that new infections are happening through different modes of transmission across country. And that really, might have an impact in terms of the work that you're engaged in and what you're seeing, right, within your context, and how that might vary across the country. So as we've seen with the last two infographics, right, certain populations are overrepresented in the HIV epidemic in Canada because they disproportionately experience a range of structural and social factors that can create health inequities, right? So these are unfair differences in health status. These factors and the resulting inequities can increase vulnerability to HIV, create barriers to health services, and lead to poorer health outcomes for people living with HIV in these populations. In Canada, the HIV epidemic is concentrated in marginalized communities, notably sexual minorities and communities of color, due to the structural and social factors that create those health inequities, right? And so the populations that are disproportionately affected by HIV in Canada include two-spirit, gay, bisexual, queer, and other men who have sex with men, people who inject drugs, Indigenous peoples, African, Caribbean, and Black communities. There's also people who are incarcerated. And while these populations have higher rates of HIV and carry a higher burden of HIV compared to the larger population, this doesn't mean that being a member of one of these populations is a risk factor for HIV, right? So identity isn't the risk factor. It is more so the context of things like racism and colonialism. So the intersections of many factors and experiences over an individual's lifetime can lead to increased and decreased risk among people within these populations. It's also really important to recognize the strengths and protective factors that exist within each of these communities and groups of people, and to work toward building upon those strengths to support and enhance health and wellness. Okay, so let's dive into how HIV is transmitted before talking about testing, prevention, and treatment. But first, I have a question for everybody. What is the difference between HIV and AIDS? And so for this, you can use the chat. Only I will be able to, I think Abby might also be able to see your answers, but just, yeah. So I think only Abby and I will be able to see the answers here. As you're answering my question, I will take a quick look at the Q&A to see if anybody has written in. I'm seeing, okay, so I'm seeing AIDS develops once HIV, destroys or significantly impacts the immune system. I'm seeing AIDS can happen from not being on meds when one is living with HIV. Stage of developing the virus. My apologies. Sorry. There's quite a few responses coming in. This is great. It's lovely to see the participation. I'm seeing HIV is the infection, and AIDS is the impact or of the immunodeficiency. Great. Yeah. Um, Progression of illness and body systems involved. Right. Okay, lots of responses here. Great. Thank you all for sharing your thoughts. Um, I just noticed that there might be an option also to share more generally, and you can maybe also share in the main chat. So apparently there is that option. Okay, just so people are aware of this. My apologies. I did not know, but I've just been informed. Um, Great. Um, I'm seeing there's one response that says HIV viral load is so high that it can no longer be decreased. Actually, with treatment, we can. But we'll get into that when we talk about treatment. Um, and then I'm seeing, and I'll end with this response. Somebody wrote, so HIV is the virus that you can carry, not guaranteed it will turn into AIDS. Yeah, exactly. So with treatment, people living with HIV can live long, healthy lives and never reach that point where they develop AIDS. That is correct. So as you can see, there is an important distinction between HIV and AIDS. HIV stands for the human immunodeficiency virus. AIDS stands for acquired immunodeficiency syndrome. If HIV is not treated, the immune system becomes weaker over time, and people can get sick with life-threatening illnesses. With early diagnosis and treatment, people living with HIV can stay healthy and avoid developing AIDS. The vast majority of people diagnosed with HIV in Canada will never develop AIDS due to being on treatment and accessing HIV-related healthcare and social supports. The other piece is somebody mentioned in their responses viral load. And I do want to point out that back in the mid 90s, when they started to use what's known as combination therapy to treat HIV, and in fact, at that time, they were able to actually treat people who were living with AIDS. What they saw was that in many cases, people's health dramatically improved, right? That was the start of really developing the kind of medication landscape which has improved over the years through to today. And so what we know is that the meds are really good at bringing down viral load. But what is viral load? So we'll switch gears and I'll ask this question now. What is CD4 count? What is viral load? And if you could just share your responses in the chat, either to everybody or to just the hosts and panelists, it is up to you. So the question again is, what is CD4 count? What is viral load? And give folks a minute to write their answers. Great, so I'm seeing viral load is the amount of virus in the blood or number of copies of virus detectable in a blood sample. I'm seeing CD4 as number of CD4 cells in a blood sample. Great. And some people have some more technical answers here, using words like helper T cells, specific type of white blood cell to define CD4. Great. CD4 cells are the cells that the HIV virus attacks. Yeah. Um, Perfect. Great. So we'll give our sort of little technical definition here, just in case it's helpful, but it seems like many people in the audience are already aware. So CD4 cells, this refers to a type of white blood cells that plays an important role in the immune system to fight off germs. And CD4 cells respond to infections and they organize a coordinated response by the immune system. And the CD4 cell is also, it plays this role or context, we can contextualize it in HIV infection as well. They play a role in the immune system to fight off germs, but it is also the cell that HIV preferentially targets, right? And so we have some information on the slide as well. It's a CD4 cell count then is a measure of the strength of the immune system. A CD4 cell count is measured as the number of cells in 1 cubic millimeter of blood. And generally, a CD4 cell count above 500 is considered to be within the normal range. The small video on viral load, I just want to make sure that that the audio is correctly set up on my end. Oh, might not, it might be a little bit quiet. We'll see what we can do, but hopefully it works. Oh, there we go.
Viral load is the amount of HIV in the body of someone with HIV. The viral load of a person living with HIV is the most important biological factor that can increase or decrease the chance of HIV transmission to an HIV negative person. A high amount of HIV in the body.
Oh, my apologies. I paused it because I thought the sound was not good, but I'm glad it is.
A high viral load can greatly increase the chance of HIV transmission. On the other hand, a low viral load can dramatically lower the chance. We now know that people who are on HIV treatment and have an undetectable viral load cannot transmit HIV to others through sexual activities. Viral load is highest shortly after someone gets HIV and is also high among people who are not on successful treatment. It is very important to diagnose, support, and offer treatment to people as soon as possible after they get HIV. It is also important to support people to stay on treatment over the long term, to stay healthy, and to live a long, full life. HIV treatment also helps to prevent further transmissions in the community.
All right. So I hope that that was helpful in defining viral load. And so this is where we'll sort of get into a little bit of a conversation on how HIV moves from exposure to infection. And it's important to understand this just in broad strokes to further understand how prevention works and why. Now, before we do this, I just wanted to ask, are there any comments or questions so far about anything we've talked about, especially with regards to just some of the biology? We're doing okay. Just wanted to leave time because I know it's a lot of information. Okay, if at any point you have questions, please type it in the Q&A box. The next thing we're going to chat about is the HIV transmission equation. So what is needed for there to actually be a risk of transmission? So let's get into it.
The HIV transmission equation breaks HIV transmission down into three necessary components: fluid, route, and activity. There needs to be a bodily fluid from a person living with HIV that contains enough HIV to cause infection, a route within an HIV negative person that HIV can use to enter that person's body, and an activity that brings the fluid and route together.
Okay, so I know there are some folks in the room that already know this, so please use the chat to respond to this question. What are the fluids, the bodily fluids that are involved in a potential HIV transmission? Great, I'm seeing blood, that's correct. That's certainly one of the fluids. I'm seeing semen, yep, that's another fluid. There's three more. Yep, so we'll include pre-cum as part of, so semen, pre-cum, or otherwise known as pre-ejaculate. I'm seeing, yep, vaginal secretions. I think we have all of them here, right? So anal secretions or rectal fluid, and we're seeing breast milk. Yeah, I think, and so we've covered all of them. So blood, semen, pre-ejaculate or pre-cum, vaginal fluid, rectal fluid, and breast milk. And just to clarify, HIV is not transmitted through saliva, sweat, or tears. And, you know, thinking back to that other video clip that we saw on viral load, even though these 5 fluids can be involved in HIV transmission, please remember that it is important to remember that a person on effective HIV treatment will have an undetectable viral load, which changes the transmission equation, right? Especially when we're thinking about sexual fluids. The next question I have is, what are some ways HIV can get into the body when we're thinking about routes from the HIV transmission equation? What are some ways HIV can enter the body? It's not quite activities, but routes. Okay, so I'm seeing open wounds, or the idea of like exposed entryway into the bloodstream, right? Injection drug use, okay, a vein, yeah. So the idea of injections, right? So breaking the skin, seeing breastfeeding. Someone has written in birth, actually, that's very rare in the Canadian context, because most people are on treatment these days. Um, and if somebody is on effective treatment throughout pregnancy, including prior to conception, throughout pregnancy and delivery, there is no risk of transmitting HIV in that context. But yeah, in general, so, you know, certain sort of body parts, right? So the vagina and the cervix, the rectum, the urethra, the inside of the foreskin, if there are, like, you know, this idea of like really open wounds, that kind of context, or injections and piercings, you know, and I think, yeah, so and then in the case of breastfeeding infants, mouth, throat, and gut. But that's very specific to breastfeeding infants. So let's talk a little bit about activities that can bring the fluid and the root together during the transmission of HIV. And actually, right before we do that, I do want to make a point here that not all or even most exposures to HIV will lead to an infection, because it is difficult for HIV to complete the steps that are required for infections to take place. Both biological factors and prevention tools will impact the chance of HIV transmission happening. Just seeing a note in the chat. It's really low. So there's a question in the chat around chances to get infected through needle stick injury. It's considered like a rare exposure. It's not common. Yeah. So what are some common ways in which HIV is transmitted in Canada? And here we're thinking about those activities that can bring fluid and root together. And just to follow up on that one comment about needle stick, that is different than like a venous puncture, right? So needle stick is a different context than, for example, like IV drug use. So I'm seeing sex, drug use. I'm seeing injection blood to blood. Yeah, I think people are definitely on the right track here. So very common, so I say very, my apologies. Commonly in Canada, HIV can be passed through anal sex, vaginal or frontal sex when no prevention methods are used, right? So in these two contexts, or when there are gaps in prevention. And also, sharing injection drug use equipment is always considered high risk, okay? Interestingly, we'll talk a little bit about the tattoo context. I think it's come up a couple of times. We'll talk about it. And so these three modes of transmission that you see on the slide are the most common ways. Other ways that HIV can be transmitted, but not as often, would be through sharing tattooing and piercing equipment, through pregnancy or birth, and or breastfeeding or chest feeding, and more rarely, needle stick injury. And the reason for that is because when it comes to things like tattooing and piercing, most places are regulated. Now, if you are supporting people within a more community context, where, you know, if there isn't like a regulatory context there, or if there is like the case of equipment being reused or reshared, then yes, there is a risk. So just broadly speaking, we sort of say that tattooing and piercing equipment, it can transmit HIV, but not as often. In the Canadian context, what we see is it's not as often as these methods that are listed on the screen. And again, just a note about pregnancy and birth. When effective HIV treatment is used throughout all stages of pregnancy and the pregnant person maintains an undetectable viral load and they remain engaged in care, HIV will not be transmitted during pregnancy or delivery. And in fact, for people who might be curious about this, vaginal births, frontal births are the norm. And they've been the norm for a while. And so here are, there's a list here of activities that rarely transmit HIV. You can see that it includes oral sex, tattooing or piercing, and needle stick injury. And let's just briefly chat about this. When it comes to oral sex, the chance of HIV transmission from oral sex ranges from very low to zero, depending on the type of oral sex. Any chance of HIV transmission through oral sex would only apply to the person who is using their mouth, not for the person who is receiving oral sex on their genitals. For people using their mouths to perform or give oral sex, HIV transmission can happen through sores or cuts in the mouth or through the mucous membranes of the mouth and throat if the person with HIV ejaculates in their mouth. However, the chance is very low. There is almost no chance of getting HIV from performing oral sex on a penis when the person does not ejaculate, or from performing oral sex on a vulva. When it comes to tattooing and piercing, again, HIV can be transmitted through blood that remains in used needles or other equipment, including ink used for tattooing or piercing. This can happen even if the amount of blood is so small that it can't be seen. However, again, most tattooing and piercing in Canada is done using proper infection control procedures, which ensures that all equipment is new or properly sterilized between each use. There is no chance of HIV transmission from tattooing or piercing in Canada when proper infection control procedures are used. However, it is possible to get HIV from tattooing or piercing if those proper infection control procedures are not used. And so this is, again, like if something is happening in a much more community context where resources are limited and so on. So, you know, that's something to consider. Someone asked about needle stick injury earlier. It can be transmitted through a needle stick, you know, HIV can be transmitted through a needle stick injury in healthcare and community-based settings. But the use of universal precautions, also known as standard precautions, helps to minimize the chance of accidental needle stick injuries in Canada. And in addition, post-exposure prophylaxis, otherwise known as PEP, can be used to help prevent infection after a needle stick injury. And again, all three of these activities are considered activities that rarely transmit HIV. I'm seeing, yeah, great point. There's an excellent comment in the chat that raises the context of correctional institutes where resources might be limited, tattooing, you know, and this person is pointing out from their experience in supporting people that they've seen that tattooing is high risk in this context. So this is where I think, yeah, like as service providers, you know, use your judgment and your critical thinking here, and what would be most valuable for clients that you're serving, for sure. So thank you for that comment in the chat. All right. So just very briefly, HIV cannot be passed by any kind of casual contact, cannot be passed by kissing. It cannot be passed by, and actually, sorry, it cannot be passed on by kissing or by sweat, saliva, tears. or by toilet seats, swimming pools, and so on, or by insect bites. Just want to briefly mention here patient rights in Canada, because when we're thinking about serving people who might be underserved, working with people who are underserved, and they might not fully know that they have these rights, right? So patients in Canada have the right to the following: to be treated with dignity and respect, to receive health services without discrimination, to have their personal and health information protected from disclosure, to have access to their health information, unless, in the opinion of a relevant health professional, the disclosure could result in immediate and grave harm to the patient's health or safety, to refuse consent to any proposed treatment, to receive information relating to any proposed treatment, as well as options. They have the right to the recognition of their representative or substitute decision maker, and they have the right to the recognition of their advance directive. They have the right to a second opinion, as well as to pain and symptom management. And, some of these things might seem intuitive or really like easy to understand. But, I think in the work that we're doing, it's important, especially when we're working with people, who may not know how to advocate for themselves, or they might not be in a position to advocate for themselves. It can be important to just be reminded of these pieces. So on the next slide, I'm curious, how many people have heard of the status neutral service delivery model? Have people seen a diagram like this before, a little like graphic like this before? Have you come across this framework before? You can just answer in the chat. Seeing, okay, yeah, no. Okay, so this is maybe a useful model to share. Okay, so this HIV status neutral approach to HIV care really means that all people, regardless of HIV status, are treated in the same way. And what we're really saying here is whether people are testing positive or negative for HIV, people should be treated the same way as they engage within the healthcare system, leading to a common final goal where HIV is neither acquired nor passed, and where people are treated with dignity regardless of their status, right? And so the two pathways after an HIV test are as follows. A person would be diagnosed with HIV, that can happen, and that person is ideally linked to treatment engagement and can actually begin HIV treatment that same day. And then they would be continuously provided with high quality care that keeps them coming back and staying healthy with an undetectable viral load. And they will not pass HIV through sex. And as we also discussed, they will not pass HIV through stages of pregnancy or delivery if they are undetectable throughout pregnancy and delivery. The other outcome, after an HIV test is that a person tests HIV negative. And they would then be linked to prevention and engagement services. For some people, that might mean starting PrEP, right? So pre-exposure prophylaxis, or it might mean starting post-exposure prophylaxis immediately. For others, it might mean ongoing testing for HIV and other sexually transmitted and bloodborne illnesses and infections. And if they remain engaged in healthcare, they will then have tools to remain HIV negative and stay healthy. And so this is sort of an approach that kind of, what we're really saying is all people, regardless of HIV status, are treated in the same way. And I'm curious, so there are some questions on the slide. I'd love to see your responses in the chat. Is this model being used in your work, even if your workplace doesn't call it status neutral? Is this something you're seeing being implemented in your work? What are some of the benefits you can see using this model? Are there barriers to implementing this model in your context? seeing a quiet chat. I was hoping to give my voice a tiny bit of a rest as everybody responded. So maybe I'm getting the impression that this is fairly new. Is that correct? No, okay. So somebody's written, and I would say we are using this. Okay, that's really exciting to hear. We already implement this in our testing. Wonderful. Yeah, and this is the thing, like, whether we call it a status neutral service delivery model or whether, this kind of approach is being implemented without necessarily calling it that, that's okay too. So I'm seeing my past workplace, which is a sexual health clinic, did and does use this model without having called it that outwardly. Yeah, for sure. Um, Wonderful. Yeah, it reflects a harm reduction approach. Great. Yes. Um, yeah, I feel like this already happens in my workplace, but it's nice to see an actual model for it. Yes. Yeah, it kind of just helps visualize, right? So that can be sort of a useful, great, wonderful. We'll share now a video.
You're like most people, you may not realize there are many ways to help prevent HIV. HIV is most often passed through vaginal or anal sex, or from sharing needles or other equipment to use drugs. Let's go through 7 of the most effective ways to prevent HIV. For the best protection, these HIV prevention methods need to be used consistently and correctly. Pre-exposure prophylaxis, or PrEP, is a medication that an HIV-negative person can take on an ongoing basis as prescribed by a doctor to help prevent HIV. Post-exposure prophylaxis, or PEP, consists of medications that an HIV-negative person can take after they might have been exposed to HIV. It needs to be started as soon as possible, and definitely within 72 hours of a potential exposure. It is taken every day for 28 days. HIV treatment helps people with HIV stay healthy, and it helps prevent passing HIV to others. When someone is on successful HIV treatment, they cannot pass HIV through sex. Successful HIV treatment also helps to prevent HIV from passing through sharing equipment when using drugs, but we don't know by exactly how much. HIV treatment, PrEP, and PEP do not prevent infections other than HIV, so it's a good idea to consider using additional strategies to prevent other sexually transmitted infections and hepatitis C. Condoms can be used during sex to help prevent HIV and other infections. There are external and internal condoms. There is very little or no chance of HIV passing through oral sex, fingering, hand jobs, or mutual masturbation. In some situations, you might avoid vaginal or anal sex and choose one of these types of sex to help prevent HIV from passing. However, keep in mind that other sexually transmitted infections can be passed through some of these types of sex. If you use drugs, using new equipment every time means that HIV or other infections, such as hepatitis C, cannot be passed. If you inject drugs, you can choose to take drugs in other ways that carry very little or no chance of HIV passing, such as by swallowing, snorting, or smoking them. Some of these methods do not prevent hepatitis C, so it's still best to use new equipment each time. There are many options to choose from. Think about which ones might work best for you. To learn more about all of the different ways to prevent HIV, talk to a healthcare provider or visit your local HIV organization.
And I will just say that that link to HIV 411 is outdated. It's now where to, and so if you visit CATIE, there is or if you visit where to, we've updated sort of this repository of different resources, organizations, and so on. So as you can see, there are multiple ways to actually prevent HIV. And we've tried to integrate in that video sort of a more comprehensive lens that also includes implications for hepatitis C transmission and prevention as well. Just go back to sharing my screen here. There we go. And so let's now dive into a conversation about prevention. Thank you for adding the link in the chat, Abby. That's great. So how many people have heard of PrEP, or I should say HIV PrEP? Anyone? Yes, we use it in our clinic. Wonderful. So we have some experts in the room. And then if you haven't heard of it, that's okay as well. We'll go over it. So what is HIV PrEP? Pre-exposure prophylaxis, also known as PrEP, is an HIV prevention method that can be used by people who are HIV negative and at ongoing risk for HIV. PrEP is taken before and after potential exposures to HIV and is a highly effective way to prevent HIV transmission when used consistently and correctly. Excuse me. The medication works to prevent HIV from replicating within the body's immune cells, which prevents nearly 100% of permanent HIV infection. It involves taking antiretroviral medications, which are the same drugs that are used to treat people with HIV, and being on PrEP also requires, or getting PrEP also requires a prescription from a healthcare provider, as well as attending regular medical appointments for monitoring and support. Okay, we'll keep going here. And some of those points will be reiterated on this next slide. So PrEP is a combination of two medications. When it's, my apologies, well, there we go. Daily PrEP is a combination of two medications in a single pill that a person takes starting before and continuing after they might come into contact with HIV. And it's for anyone at risk for HIV. It is used to prevent HIV in a wide range of people. So, whether it's for anyone at risk. So trans people, gay, bi, men who have sex with men, women, including like cis and trans women, anyone breastfeeding or chest feeding, pregnant people, and so on. So it's for anyone at risk for HIV. Adherence is really important. Adherence means taking medication exactly as prescribed, and this is crucial for PrEP to be effective. A large body of evidence shows that daily PrEP is highly effective at reducing the risk of HIV transmission when adherence is high. And then finally, PrEP can also be used by people who may be at risk for HIV through sharing drug use equipment. But just to note that people who use drugs need full access to proven harm reduction strategies and enough new equipment to be able to avoid having to reuse equipment or share with others. So full suite of harm reduction options are needed. Can also chat a little bit about on-demand PrEP. And so this is, oh, my apologies. So there is usually a graphic here. I'm not sure why the graphic did not show up on this slide. My apologies. I'll definitely update it for the slide deck that we send out. But on-demand PrEP is when a person takes PrEP only on days before and after having sex. So the term PrEP 211 refers to the dosing schedule, which involves taking 2 pills 2 and 24 hours before sex, 1 pill 24 hours after the first dose, and finally 1 pill another 24 hours later. And only the formulation of TDF and FTC can be taken as on-demand PrEP. The Canadian guideline recommends on-demand PrEP as an option to prevent getting HIV through sex for cisgender or cis men, including gay, bi, and other men who have sex with men, as well as heterosexual men, as well as for trans women. And several studies among GBMSM and trans women have shown that on-demand PrEP is as effective as daily PrEP when it is taken correctly within these populations. Now, the effectiveness of on-demand PrEP for cis women, trans men, or in the context of drug use is unknown, and it is not recommended for use within these populations because there is currently no research on the 211 dosing schedule in any of these groups. People who do take PrEP on demand don't need to take it for 7 days in advance. They only need to follow the 211 regimen correctly with their loading dose of 2 pills between 2 and 24 hours before having sex, and continue to take the next 2 doses. So sort of 4 pills total per sexual event. And if a person continues to have sex, they should continue to take a pill every 24 hours until 2 days after the last time they have sex. And again, the slide deck does include the dosing schedule as a mini little graphic here. So my apologies, I'm not sure why it didn't show up on this slide. It will be there in the deck that is sent out. I also wanted to share some information about long-acting injectable PrEP. So one long-acting injectable is approved by Health Canada. This is cabotegravir. It's an injection every 2 months. And the other, lenacapavir, which is an injection every 6 months, is not approved yet. It's expected to be approved in mid to late 2026, and it will be a number of months before it is available on provincial and territorial formularies and available through national benefits. And even injectable cabotegravir is not available on most formularies yet. So, but this is informational, right? And these injectable options eliminate the need to remember to take a pill every day, and instead appointments for injections would be spaced out over the course of months. But again, there are some questions and considerations here around access and so on. I'm seeing, so the medications are more effective for men is the question in the chat. So it's the dosing schedule, right? So let's be very careful so daily PrEP is for anyone at risk for HIV, anyone at risk. So cis and trans women, including anyone breastfeeding, chest feeding, and pregnant people. It's also for trans people, people who use drugs, gay, bi, and other men who have sex with men, and anyone else who may be at risk for HIV. That's daily PrEP, taking it every day. On-demand PrEP, this is when a person takes PrEP only on days before and after having sex with the 2-1-1 dosing schedule. This, what they've seen is that on-demand PrEP is as effective as daily PrEP for GBMSM and trans women. So it's the dosing schedule. It's not the medication itself. Does that make sense? Okay, awesome. Yeah, I don't want anyone to leave with the impression that PrEP is not for women. Absolutely, PrEP can be used in women, and it's a proven strategy. Okay, so back to the context of long-acting injectable PrEP. The forthcoming updated PrEP and PEP guideline. So this hasn't been released yet. Oh, I'm frozen. Can people see me? Just making sure that people can see me okay. I think I was briefly frozen. Okay, wonderful. So there's an update being made to the Canadian PrEP and PEP guideline. So it's forthcoming. It hasn't been published yet. It currently only mentions long-acting cabotegravir because that is what is currently approved. So there is another one, right? So lenacapavir, which is not yet approved, but we anticipate, like, in the next or not, but it's expected to be approved in mid to late 2026. The updated Canadian PrEP and PEP guideline, again, it's not yet published, but it will recommend injectable cabotegravir as a potential option for anyone, all genders and sexual orientations, who may be at risk for HIV through sex or from sharing drug use equipment, injection drug use equipment, my apologies. And so that is just something I wanted to share. And just because it's come up already once, I just want to clarify that both long-acting formulations in studies and so on, cabotegravir and lenacapavir, have been shown to be highly effective in preventing HIV in diverse populations, including cis and trans women. Okay. So we've talked about pre-exposure prophylaxis. The other effective strategy that uses HIV medications to prevent HIV is PEP, which stands for post-exposure prophylaxis. So has anyone heard of PEP? Great. Awesome. Wonderful. Seems like many people have heard of PEP. So to be effective, right, PEP needs to be taken um, as soon as possible after a potential exposure and no later than 72 hours after. And it's important to take the pill as prescribed for PEP to work. Now, someone in the chat has mentioned that the window or that window of 72 hours is more than they thought. The idea is to take it as soon as possible. So the sooner the better, and certainly within 72 hours, Christine, if that makes sense. So people are encouraged to take it as soon as possible, which might be why the framing is, yeah, exactly. And so PEP is used by people who are HIV negative to help prevent them from getting HIV. And this can include in cases of unprotected sex, which can happen in consensual contexts. It can also happen in non-consensual contexts, right? It can happen with a condom breaking during sex or sharing equipment used to inject drugs. It's taken, again, as soon as possible after potential exposure to HIV, up to a maximum of 72 hours. It's a combination of 3 medications that an HIV negative person would take orally for 28 days after an exposure to lower their chance of getting HIV. And again, ideally taken as soon as possible after that potential exposure for the full course of 28 days. And it is for anyone at risk for HIV. So PEP can be used to prevent HIV in gay, bi, men who have sex with men, women, trans people, people who use drugs, people who are pregnant or breastfeeding, or anyone else who may be at risk after consulting with a doctor. One point I want to make here is that it's intended to be used to prevent HIV transmission from a single exposure. So keep in mind that, when somebody starts a course of PEP, they are taking it for 28 days. So you don't really want any more exposures to happen within that time frame because that can reset the clock for taking PEP, right? So we want to give PEP the best shot of working, right? Or the best chance of working, I should say. The other piece is, who has heard of PEP in pocket? Has anyone heard of this? PIP. I'm seeing a question in the chat. No, it's intended for so a clinician. So there's 2 questions in chat. One is there any calculation or calculator you can recommend to help give the patient an idea of the risk of the exposure for when they're deciding whether or not to take PEP? So the idea is an exposure, right? A single one-time unintended exposure. And to take it within 72 hours as soon as possible in that time frame. But I think what you're asking is like questions around whether it was actually risky activity. Is that correct, Cassandra? And I think Bev is asking a question that's similar. I think so. This is best sort of decided with a clinician, with a provider that is like prescribing PEP. Let me look into that, and I can I think there might be some tools, but I'm not sure. I'll take a look and get back to you. That's a great question. And similarly, Bev, let me go back and check. I certainly know that there have been cases of PEP prescription where status is unknown. So it's not only taking it if you know the other person has HIV, there are some other considerations. People in context of exposure with unknown status may also be prescribed PEP. Yeah. Yeah, actually, and if you have that calculator, Cassandra, if you want to put it in the chat, that's very helpful. Has anyone heard of PIP, which is PEP in pocket? I'm seeing a question about short. It's not a shorter course, no. But like good guess and engagement. No. So PEP in pocket, right? It's this idea that PEP only works as a way to prevent HIV transmission when started as soon as possible after potential exposure to HIV, right? Like you really want to get it within that 72-hour window, and you want to start as soon as possible. Now, there have been some communities and agencies that have started supplying a prescription in advance for those who might benefit from having this option, right? So the idea is that, PEP is for emergency situations. Typically, one would go to the emergency department for PEP after a potential exposure, whether it's via sharing injection drug equipment, whether it's through sex or sexual assault, right? And so with PIP, the idea is that you already have a prescription on hand before the exposure, right? So it's a good fit for people who may find themselves at increased risk of HIV transmission, but not as often as somebody who might be taking PrEP, right? And so there is this idea of potentially having PIP. But I will say access is quite limited to PIP. It would involve needing somebody to prescribe PEP in advance. And that sort of really depends by clinician and so on. Okay. We'll move on to one more method of prevention. I just wanted to briefly mention, so we've talked about PrEP and we've talked about PEP. So both PrEP and PEP are taken by HIV negative people. The next strategy we're going to share more so has to do with the context of highly effective treatment. And I'm curious, has anyone heard of undetectable equals untransmittable or U equals U? Wonderful. Great. This is actually, and I'm seeing some people haven't, and that's okay. We're going to go into it. And many people have. And, I got to say, from working in HIV for over 10 years now, it's actually it's really inspiring to see more people know about it. And it's come a long way in terms of, just getting the message out there. So that's exciting, but we'll go over it. So when it comes to undetectable equals untransmittable, let's first talk about the benefits of an undetectable viral load, right? And we're going to talk in a minute about effective treatment for people living with HIV as another highly effective way to prevent HIV, but really an undetectable viral load, which happens when somebody is on effective HIV treatment. This has two important benefits. First, it helps people living with HIV live long and healthy lives. And a secondary benefit is that it helps prevent transmitting HIV to others. But the prevention benefits vary depending on the route of transmission, right? So I've already mentioned two ways in which if somebody has an undetectable viral load, they cannot transmit HIV. Does anyone remember what those two contexts are? So they will not if somebody is on HIV treatment, they maintain that undetectable viral load, which is to say levels so low that lab tests cannot detect it. When that happens, they will not transmit HIV through sex. Exactly. So that's the first point. And they will also not transmit HIV through, there's one more. So it's pregnancy. So when somebody is on HIV treatment and they maintain an undetectable viral load, they will not transmit HIV through sex, and they will not transmit HIV to their baby or to the fetus during pregnancy or delivery. And this is if they're undetectable throughout their pregnancy and delivery. Okay. The chance of transmitting HIV through breastfeeding is very low. So it's not zero, it's very low. Just the guidelines, or I should say, my apologies, the consensus recommendations for infant feeding in the HIV context still recommend formula feeding as the #1 recommendation. However, they also do talk about the case where if somebody wants to breastfeed or chest feed, that there are now options for them to be able to do so as safely as possible within the context of a care team and additional supports for the parent as well as the infant and so on. But so when somebody is undetectable, the chance of transmitting HIV through breastfeeding or chest feeding is very low. The chance of transmitting HIV from sharing equipment for using drugs is also reduced, but we don't know exactly by how much. So the first two bullet points here are the cases where undetectable viral load completely eliminates the chance of transmission. And the last 2 points here, there is a reduction in risk of transmission. Does that make sense to everyone? Just want to make sure we're all on the same page. Perfect. And you might have this question of like, okay, there's this sort of, phrasing here around somebody has to be undetectable throughout pregnancy. Well, what if somebody begins HIV treatment only after conception and then they maintain that undetectable viral load for the remainder of their pregnancy? In that case, there may be a small chance of HIV transmission through pregnancy. But in general, in Canada, most pregnant people, the vast, vast majority, are on effective HIV treatment. So just wanted to make that very clear. And the final piece with, just want to also mention in the context of injection drug use is that, we've seen time and again, it's best to use new injection drug use equipment every time to prevent HIV. Again, people who are using drugs need that full suite of harm reduction supports. I'm seeing a question. Yeah, so there is the sort of context of like, well, can I get it this way? Can I get it that way? And so on. The activities, I'll put it to you this way, right? So the activities that most commonly pass HIV in Canada are through sex and sharing injection drug use. There are other like theoretical ways, but the thing is, you want to imagine it like this epidemiologically, right? If, for example, the scenario you've raised in the chat were to be happening so frequently, we would see it in the numbers, right? So like there are certain things that we can say, okay, biologically, maybe a theoretical risk, potentially. Does it happen that often? Like enough to show up as a common way of transmission? No. Does that kind of answer the question? I don't know if that answered the question, but okay, so we'll keep going here. When we're thinking about sorry, before going on, I'm seeing the question in the chat. So is it's possible, but not common. I think like when we're considering sort of unique scenarios of HIV, for example, this question is, can you get HIV by having semen thrown in the eye? It is like, I will say that the most common ways of transmitting HIV in Canada, what we see in the numbers is through sex and through injection drug use, right? Shared injection drug use equipment, and sex where there's no prevention or strategy. So other scenarios are not happening in a way where it's really showing up as a metric, but like in general, like mucous membranes and wet linings of the body can be permeable to HIV. So that is the answer that I would give there. Okay, so harm reduction, just briefly mentioning this, it's an important part of supporting the rights and health of people who use drugs, right? So there's this growing demand for harm reduction information by all types of organizations that are providing services to people who use drugs in Canada. The toolkit that we have provides foundational information on harm reduction for service providers who are working with people who use drugs. And this includes support workers, outreach workers, nurses, as well as workers with lived and living experience. And this toolkit is free to access. It is available to anyone to use or share for personal learning, organizational trainings, and or other capacity building efforts. We're happy to also send it out by email. afterwards. And so, yeah, so we'll keep going here. Can briefly move into a conversation about HIV testing. There are many benefits of HIV, there are many benefits of testing for HIV. And so, when we consider this, we're really thinking about knowing one's status. We're thinking about better health outcomes, and we're thinking about accessing additional services, right? So in Canada, about 10% of people living with HIV don't know their status. And the only way for a person to know if they have HIV is to get tested. We also know that starting treatment as soon as possible after acquiring HIV is important for health. And what we notice is that early detection and early treatment can lead to better health outcomes. And finally, we also know that knowing your status can also help prevent passing HIV to other people. And we also know that getting tested increases opportunities for relationship building, bringing people into support. And then, whether the result is positive or negative, there is this entryway into care. There's this status neutral approach that can occur. There's also a wide range of prevention opportunities that can arise in the case of negative tests, like things like new and unused drug use equipment, condoms, PrEP, and so on. We'll touch very briefly on HIV testing. I will post a fact sheet in the chat that covers this in much more detail. All HIV tests in Canada require a blood sample. There are a few ways that people can access HIV testing in Canada, and the most common way to access an HIV test is from a healthcare provider's office, but it can happen in a variety of healthcare and community-based settings like hospitals, public health clinics, sexual health clinics, health centers, pharmacies, mobile vans, and other outreach settings. It's really like diversity here. And the availability of testing in settings outside of healthcare providers' offices varies by province and territory. So here I'd like to ask everybody a question. What are some ways in which people are accessing testing in communities that you're serving? How are people getting tested? And are you supporting testing directly? Yeah, so I'm seeing sexual health clinics, health bus, community clinics. I'm seeing a research project, 3 infections, 1 fight. Could you share a little bit more about that, Heather? Would it be Hep C, HIV, and syphilis, or something else? I guessed. I could be wrong there. I'm seeing through harm reduction services, people coming into corrections and then offering them testing, pop-up clinics, seeing blood samples taken at clinic, ER, so emergency rooms, safe injection sites. Yeah, so yes, so there's a clarification that there's a program that is fighting sort of three at once, so HIV, hepatitis C, and syphilis. Seeing public health through corrections facilities, offering treatments for syphilis on the spot, as well as confirmation of blood work. Yeah, this is really great, Heather. It sounds like you're implementing something that we call at CATIE test for one, test for all. And I think that, that's really important. We also have a micro learning course on syphilis through CATIE. And so we also have a syphilis workshop, I believe. And actually we worked on we partnered with Saskatchewan Prevention Institute earlier this year to deliver that syphilis workshop. Yeah. Wonderful. I'm seeing Wellness Wheel goes out in community and First Nation communities. There's liver health days, community drop-in sites. So that's more of I guess with the liver health day, you're talking more about hepatitis C there. So again, this like test for one, test for all approach. Or maybe that one has more of a hep C focus, but then Wellness Wheel also does, of course, the HIV testing as well. Great. Thank you for sharing your thoughts here. As you can see, there's wide variability in what testing looks like. And yeah, and that also means there's wide variability in access, right? So to access a test from a healthcare provider or community worker, a person can voluntarily request a test, or a provider may offer the test to the person seeking care. In both cases, a person must consent before having an HIV test. Blood may be collected at the place where the test is offered, kind of like, we're hearing about pop-up clinics or on-the-spot testing and things like that, point of care testing, or a healthcare provider may give a person a requisition to have blood drawn at a local laboratory. There are self-tests that are available for purchase from a manufacturer. They may also be available in some pharmacies. They may be available for free through some community organizations and research projects, but access is limited. And no matter the kind of test, these 3 C's are really important. So having pre and post counseling around the test. My apologies. I was doing so well without the cough, as well as confidentiality and, of course, consent. And usually the consent happens verbally. Let's talk about the window period. And before we dive in, what is the window period? Does anyone want to share a definition of the window period in the chat? What do we mean by window period? Yeah, great answer in the chat. The time between like an infection happening and that infection being able to be positive or detected on a test. Yeah, exactly. So no test can detect HIV immediately after infection. And the idea of that is the window period, right? Because it's the period of time when a person is exposed to HIV to the time when an HIV infection can be detected by a test. Now, the window period can vary between 2 weeks and 3 months. The length of the window period varies from person to person and with the type of test used. Why do you think the window period varies from person to person? Not just by the type of test, but by person to person. Immune system, yeah, exactly. So different people develop markers of HIV infection that are detected by HIV tests, slowly. So, and then some people develop them more rapidly, right? So, and then the type of test will also look for different markers that can occur at different times. So again, it ranges from 2 weeks to 3 months. The period of time when oh, my apologies. We'll just keep going here. If the person has a negative test result, but is in the window period, then they should be advised to when to test again to get a definitive result, right? And so, for example, this would happen if their body had not started producing those markers of HIV infection at levels that are detectable by the test. Right? Some provinces recommend testing at intervals until the end of the window period to pick up HIV infection as early as possible. Is that something that you're seeing in Saskatchewan? I'm not sure. This is my question to all of you. For you are experts in your context. The other piece to think about is that if at any point a person gets a positive result from a confirmatory test for HIV, it means that the window period is over and that the person has HIV. I'm seeing 4 blood tests over your span. I think that is more so about the context of routine testing, right? So making sure that people are regularly engaged in care and testing. And as we'll see actually on the next slide, there is this idea, right? So testing is that important entry point into both prevention and treatment services. And yes, if somebody is testing negative regularly, but they're coming in regularly for getting tested, then they're engaged in prevention, right? So what are some of the services that you're seeing people getting linked to when they're coming in for testing? Now, testing is this important entry point. What else are people getting connected to? What other services? Seeing addictions, potentially treatment. Yeah, if they test positive. And if they test negative, I'm seeing education on PrEP and PAP, HIV case management. So I guess in the case of testing positive, nursing, public health for vaccines, counseling. Right. So for other health related contexts, great. Yeah, and so we're seeing how testing can be an entry point for a wide range of, social services, as well as, prevention services, as well as treatment services, right? Yeah, and so people, who are testing negative, certainly sexual health prevention options and, sexual health services, including prevention options, repeat testing, um, harm reduction, housing, and mental health services. And then, when we're thinking about people who are diagnosed with HIV, yes, there is this piece around being linked to, engaged, and retained in care and treatment. But also like things like peer support groups potentially, like really supporting people with the social side of things, dealing with some of the challenges that may arise in terms of processing that diagnosis. There can be kind of some tough feelings that might arise as well, so counseling and so on, right? Information and services also related to prevention, so like having that empowering message around U equals U can be helpful. Um, and so people might also need extra support to connect with a provider and remain engaged in HIV care and treatment. Um, and so, providing that immediate linkage to care can help people who are diagnosed with HIV become engaged in care as soon as possible. And that can increase the likelihood that they will start treatment and early and successfully, manage HIV. And so we'll talk now about treatment. We've talked about transmission, prevention, and testing. The key message around HIV treatment is that it really is a lifesaver. There is no cure for HIV, but there are medications that can keep the virus under control and allow a person living with HIV to stay healthy and live a long and full life. And so this is really thanks to a long history of powerful advocacy by people living with HIV that governments and researchers, put in the work to expand our knowledge about HIV treatment and medications that have now evolved and they've really improved over time. So the context today is that very effective HIV drugs that are easy to take and have few side effects are now available, right? Okay, let's take a look at when should HIV treatment be started. Here we mean for sort of best biomedical outcomes. And in this context, the earlier HIV treatment is started, the better the health outcomes for people living with HIV. But I really want to stress the point too that this is a major decision. It is a lifelong commitment to taking meds, and the decision to start treatment always rests with the person living with HIV, right? It's really important that people feel ready to make that commitment to taking HIV treatment on a regular basis. It's important that they feel supported in that decision. And we'll talk a little bit too about how HIV treatment works. And we'll talk about what, if someone doesn't take their medication regularly or like they need additional adherence supports, we'll talk a little bit about that as well. But first, can anyone share how HIV treatment works in the body? What does HIV treatment do? What is it doing? How is it working? And many thanks to everyone I realize it's a long session. It's a 2 hours session. I'm seeing a community-based sort of way to explain how HIV treatment works. The answer is puts the virus to sleep. I've never heard that phrasing before. That's really interesting. So thank you for sharing that. I'm seeing stops the virus from replicating. So we're seeing sort of a biomedical explanation, a much more community explanation. And I think both are really important to try and connect with clients, right? So thank you for sharing that. Um, and yeah, exactly. So HIV treatment suppresses the amount of HIV in a person's body by preventing HIV from making copies of itself. HIV treatment works quickly to dramatically slow down viral replication and decrease viral load. Most people's viral loads become undetectable within 3 to 6 months of starting treatment. HIV treatment allows the immune system to regain its strength. It increases the number of CD4 cells and it reduces the risk of serious infection. And we know that because, as we said, like way back at the start of this workshop, we know that HIV treatment prevents the progression of the illness and prevents sort of, it prevents AIDS, right? Prevents that collection of opportunistic infections and so on. And what we also know is that if someone is seriously ill, if they're starting meds later in their journey, the symptoms of HIV infection diminish or disappear, right? And that's what happened back in the 90s with the advent of the first, anti-HIV medications that actually worked to bring people back from really serious conditions, right? And so, and we're very lucky that today some of those folks are still alive and with us. And they were, many of them were powerhouses in the advocacy movement to ensure that meds were first available, that meds worked, and that meds improved. So really important to sort of honor that history and legacy. Okay. So the goal of HIV treatment, right, is the improvement of the health and quality of life of the person living with HIV. And from a biomedical perspective, what we're doing then is that the goal of HIV treatment is to stop the viral replication process and reduce the amount of virus in the body, also known as the viral load, to undetectable levels. And again, HIV treatment does not cure HIV. Even when the viral load is undetectable, HIV still remains hidden in the body. Okay. Now, if a person stops taking their treatment or does not adhere to their regular treatment schedule, like if they're kind of stopping and starting, HIV can begin to replicate again and the viral load will rise. So we'll talk about adherence in a moment and how you can support people on HIV medication to take their medication every day. But my first question to you is actually not what's on the slide. It's a separate question. Why do you think adherence is important? Why is it important biomedically to stick to the meds and take them at the correct time exactly as prescribed? It's about like the scheduling and making sure they're being taken regularly as prescribed. Why is that important? Seeing to keep viral load suppressed. I'm seeing to prevent resistance. Yeah, so let's talk about adherence and how the concept of adherence is related to the idea of resistance. Ongoing adherence to HIV treatment is very important. Without enough medication in the blood to suppress the virus, HIV will begin replicating again and it will spread throughout the body. Inconsistent adherence to treatment or stopping and starting treatment can allow HIV to develop resistance to the drugs taken, right? It does this because when HIV starts that replication process again, it develops little mutations throughout its structure. And what can happen is that it becomes resistant then with those mutations to the treatment that one was taking, right? And so when we're talking about drug resistance, what it means is that if you allow HIV to get a chance to replicate again, it might develop the ability to overcome specific HIV drugs, and it's able to sort of escape the effects of that drug. Drug resistance limits HIV treatment options because the specific drug or even an entire drug class to which that HIV medication belongs to, it might mean that basically HIV will become resistant to that medication or that entire class of medications, right? So, and then if that happens and those medications are no longer effective. At the same time, people may have difficulty adhering to their HIV treatment for many reasons, right? There's a whole social context of HIV, and we want to be really sure that we're not contributing to stigma, we're not contributing to, um, sort of like surveillance or, that kind of approach. It could just be, people might have many competing priorities. They might forget to take their pills or renew their prescription on time if they're dealing with underhousing, if they are, if they're dealing with a wide range of social and structural barriers, it can be difficult, right? If they don't have space to store their meds, if they have difficulty maintaining a constant and reliable supply of medications, or they might be experiencing some kind of fear that others might discover that they're taking HIV meds. So all of these things can pose barriers to taking meds, uh, regularly as prescribed, exactly as prescribed. What are some ways you've supported people to stay adherent to medication? We'll just give folks a minute. Okay. So people are writing in. If they have daily witnessed medication, yeah. So this is the idea that, they might have some at home and then somebody can sort of support them by sort of being like, okay, I'll watch you while you take your meds so that I can remind you later that like, yeah, you took it and, and remind you to take it. Yeah. Um, I'm seeing a very clinical approach there. Alyssa, if you want to, or, oh, I see what you mean. So administer like an antiretroviral, which is an HIV med, alongside methadone. So the idea of like habit forming, right? You want to pair the medication with something else that is happening at the same time. Got it. Um, any other? Yeah, I usually see like, I take it in the morning when I wake up. But yeah, exactly. Your option is, or your approach is very much along the same lines. Yeah. Bubble package, days of the week pill containers. Yeah. One of the advantages of a day of the week pill container is that it says the day of the week versus bubble packaging where sometimes, I mean, it depends on the kind. Like some are circular, some are, so it just sort of depends. But people might be like, yes, I did take it this way because or this day because it's no longer there, right? Alarms on phones can be useful, but what's interesting is like sometimes I've heard more from my frontline days that like the alarm will go off, but then later they don't remember if they took it or not. So pairing some of these strategies, alarm on phone, having like a weekly dosette kind of thing. And you know, I think that can be helpful. Also ensuring that meds are refilled on time, right, to avoid missed doses towards the end. Um, I've heard sometimes clinicians might ask like, hey, like, are you close to finishing your meds or whatever? But then actually just sort of like witnessing that, okay, maybe there's actually a few too many pills that are still remaining. So maybe there have been some missed doses, right? So, but it depends, like that conversation can be tricky to have, right? Depending on the relationship. Seeing support person to help you overcome barriers. Yeah, like, not just like an app or reminder, but like people maybe checking in. Yeah, for sure. Or taking your meds while somebody else is also taking meds at the same time. Yeah, like having like a buddy system, right? Yeah. Packing a few extra doses when traveling. That can be for like whether it's, living transiently or whether it is traveling in another way. Okay. Let's have a brief discussion. Um, you can answer any of the questions that are on the slides. Think about your work. You can choose PrEP, condom use, or U equals U. What are some of the successes that you've seen with regard to prevention? What are some of the barriers? Um, what are some examples of HIV prevention strategies happening in your community? Um, Really that last one, if you want to share, because we're in a space where you can promote your programs or at least like share your programs with others that are in the room. I think that might be useful. But you can answer any of the other questions as well. Yeah, I'm seeing significant barriers for people who are homeless and use substances. Yeah, that's a really, and thank you, Carla, for bringing that up. That there's a housing crisis, right, across many parts of the country, um, and certainly in Saskatchewan. Uh, my apologies. My screen, I don't know if people saw that. It looked very weird on my end. It's suddenly just, okay, I'm back. Sorry about that. Seeing a few more responses here. Reduced hours at Prairie Harm has been difficult. Yeah, because people need those supports. I think our needle exchange probably plays the biggest role for most of ours. Right. So people are coming in for other needs and then being supported with respect to prevention and so on, right? And other resources as well. Yeah. Really exciting to hear that, Danita, that there's a new HIV support program at Wellness Wheel. I'm seeing mental health concerns. Yeah, it's sort of, there's so many structural reasons how mental health concerns can arise, and then mental health concerns can also exacerbate those contexts, right? So it can be really hard to be underhoused. That can certainly create mental health concerns, which can further, um, it can be hard to get out of that cycle. Barriers of services for sexual health in Saskatchewan. Do you want to be more specific, Alyssa? Like, as in, like, there aren't services, or there are, but they're hard to access, or they're farther away. Like, um, yeah, what is the context there? I'm seeing providing condoms for participants, having open and honest conversations with clients with no judgment. Yeah, like reminding people of safe consumption sites. Yeah, and safety, it's interesting, like safe consumption, safety is part of it is also like of course it's the equipment, that piece, but then it's also like, do people feel safe? Like, do they feel emotionally safe? Can they open up? Can they actually share what their risks are? Can they share what they're experiencing in their lives? Like, are they feeling culturally safe, right? Um, Building trusting therapeutic relationships is like vital, right? Otherwise, like if that conversation can't even happen, then how can anything happen? Um, I'm seeing a comment from Alyssa. They're hard to access in rural areas, like so sexual health services, right? So there's this sort of remote context of service delivery can be quite challenging. Uh, I'm seeing recent legislative changes have created barriers for harm reduction and sexual education in Saskatchewan. Thank you for sharing that, Sarah. That there are like these sociopolitical effects, right? Sociopolitical factors that are playing a massive role in people's health and in adverse health outcomes. Yeah, for sure. Thank you for sharing that. We'll shift gears now to a case study. We'll go with this one, and then we will, if there's time, we'll do the one before this one as well. So Jamila visits your center now and then. Today she happens to be coughing, as are many in the clinic. Jamila has a few needle marks on her arms and has indicated one of her wounds might be infected. She would like support with this as well as harm reduction supplies. You see a colleague don a mask. As they approach Jamila, your colleague says, well, Jamila has HIV, so we just have to be extra careful. What would be your approach in addressing your colleague's statement? How would you support Jamila's needs around harm reduction? around her wounds, around her needs, and what kinds of follow-up support would Jamila need? So sorry for the coughing. Like I realize it must be disruptive. Yeah, this is a great response, Cassandra. So I realize you've only sent it to hosts and panelists, but it's great. My apologies, I did say your name out loud. We don't need to change our practices if a patient has known HIV. Up to 10% of people who are living with HIV do not know their status, so should treat everyone the same. Also, all patients deserve the same respectful treatment for sure. I think also that framing of like, well, you don't always know, right? Like people may not know their status. So this kind of response from the colleague maybe is also a uh little bit short-sighted or not really thinking about the full context. Yeah. Um, and then yep, and there's another response here. Explain you can't get HIV through saliva, provide harm reduction supplies, and then offer support for her wound and the conversation around everything new every time. Yeah. Great. She needs more testing, refer to harm reduction antibiotic. And I'm guessing there, Neetu, you mean like testing for other STBBIs, as in like a follow-up. Would that be correct? Given the context of using injection drugs. Antibiotics. So in the context of like also follow up with the care and the wound itself. Yeah, exactly. And I hope like what we're, getting at here is that people aren't coming in for support with just one issue, right? It's usually like, there needs to be this kind of holistic approach around people's needs. We don't want to entrench stigma. We really want to address stigma, make sure that we are operating in sort of really respectful ways and so on, right? Um, Great. We'll do, I think, one more case study. So this one is back here. Um, so Frankie has been in and out of your agency over the past couple of years. They often come by for harm reduction supplies, a meal, and to just rest for a bit. They like to read. They often grab a book from your small library. You have a good relationship with them, but not a particularly close one. Frankie seems quite independent and has been on the streets for a long time. People look up to them as an old timer, but in reality, Frankie can't be more than 35. You're surprised to see Frankie on your list of people to talk to, but pleased that they felt they could come to you with whatever is on their mind. They sit down and share that they might have HIV. They're scared, both for themselves and the people they might have given it to. I'm just going to briefly stop my screen share to put the questions in the chat this time. Just give me one moment while I bring that up. Um, and then I'll share my screen once more. Oh, I don't think I can share it in the chat. So, Abby at the Saskatchewan Prevention, I've just sent it to you directly. Could you post that in the chat, please? And then I will just share my screen. There we go. So you can see the questions in the chat related to this case study. Thanks, Sarah. So thank them first for sharing. Yeah, really honoring that they opened up, right? Um, ask them if they want to tell you anything else and what kind of support they want from you. Yeah, absolutely. Offer them options to choose from, whether it's little or lots of info, start letting them lead. Yeah, this is a very like patient-centric approach. It's meeting people where they're at. Um, Christine, yeah, firstly, I would acknowledge they're coming to talk to me. Yeah, yeah. And then sort of getting more into their exposure story, find out about what care they might need. What might be something they would need to know if they have HIV? They said they might. Offer testing, right? And yeah, part of this is also the exposure story because it's sort of unclear in the scenario. Like maybe they weren't at risk, right? Maybe they think they are, but they're not. But also potentially, yeah, and either way, validate their concerns, find out why they're concerned. Um, and then if there is a potential risk, like, yeah, like then having this conversation about getting tested. What are some ways to potentially reassure them? Not necessarily around like testing. I mean, like, how would you, like, they seem a bit anxious and scared. What are ways to support them through that feeling? Um, yeah, this is a great point to just practically following up with somebody who is living very transiently can be challenging. What are some ways to have that follow up, right? Reminding them that their information will be confidential for sure. Right, so maybe like confirmatory testing, share ways that they can control the situation. Yeah, with regards to self-care and limiting risk to yeah, and sort of just have piece two around how like, hey, like we have very effective treatments today, like just sort of preparing them to like this is part of pre-post counseling with testing, but like really having that conversation around what might happen with a positive diagnosis, right? So that they feel a bit prepared to get tested. Acknowledge the fear and stigma totally. Talk about how effective treatment can be. Yeah, exactly. Um, reminding them that HIV is treatable. They can live a long, healthy life with medication if they happen to test positive. Um, yeah, and like slightly trickier conversation there I'm seeing in the chat around notifying any possible contacts and that they can be supported in that and how to like, and you might have to have a conversation with them about like your status is confidential. And then at the same time, there is sort of this partner notification process that they can be supported with. If indeed there is a positive result, right? Yeah. What are some other supports they might need as they're navigating sort of health, mental health, and so on, right? Or I should say like embodied health and talk about PEP and PrEP if they're HIV negative. Yeah, absolutely, right? They might be testing negative. And so then engaging them in prevention services would be really important. Yeah. Also potentially repeat testing if they're within the window period, right? Yeah. Lots to consider here. So we have a few minutes remaining. I'm just going to share that this is our educational platform where our courses are hosted. We have instructor-led courses. That would be like you'd see me hop on the discussion boards, and there's an online meeting to conclude the course. Courses are usually sort of like between 3 to 5 weeks long. There's also self-directed courses. Um, I'm obviously a little bit biased. I think the facilitator-led courses are more fun and also more engaging because you get to interact with many people, not just the facilitator. There's discussion boards. You can interact with colleagues and with people that are engaging in the work either in your region or across the country, depending. And so there's definitely options here. I wanted to share also our evaluation form at this juncture. I want to thank you all for coming. So here, I will just put this into the chat. And really just thank everybody in the room, thanking the Saskatchewan Prevention Institute as well. I'm just going to share also my contact information. And if you want to, if there's any additional questions, like I'm happy to stay on until for the next 7 minutes. Like that's completely fine. And people can, have a chance to fill out that evaluation form. And over to you, Abby.
Thank you so much, Shreya. I always really enjoy your presentation style. You're like such a pleasure to learn from. And I also really appreciate doing this while you were recovering from something. I did not personally find the coughing disruptive. I learned a lot. So thank you so much for being here. And I just want to also thank everyone who tuned in today and for people who shared their professional experience and working in a Saskatchewan context. That adds really valuable information. As a reminder, this was recorded today, so I will be sending out this recording in the next couple of days, and I can also send out Shreya's information with that and some of the links that we shared and the recording here. Thank you again so much, Shreya. Thank you. Bye.